Hi, I'm Dr. Tony Prochazka and I'd like to talk to you today about eyelid surgery. Now, the eyelids are a very delicate structure. Everything's on a very small scale. It's a very fine surgery that really requires a lot of precision. Of course, we have upper eyelids and we have lower eyelids, and I would say that the majority of patients are seeking upper eyelid rejuvenation. So it is actually the simpler of the two procedures. Lower eyelid surgery is a lot more complex. Upper eyelid surgery is fairly straightforward. One of the most important things to realise with upper eyelid surgery is that sometimes there is a significant contribution from dropping of the eyebrows. As you can imagine, if the eyebrows go down, they push the eyelids down with them. So therefore, the first thing that we need to identify when I'm examining the patient is, do they also need a brow lift? Now let's assume for the moment that they don't, and that the entire problem is simply one of excess skin of the actual eyelid itself. So the approach to the surgery is pretty straightforward. It's simply a matter of cutting out skin. Directly under the skin we have the circular ring of muscle around the eye, which is called the orbicularis muscle, and usually a little bit of that needs to be removed as well. Underneath that we then find a little membrane that holds all of the fat that we find around the eyeball, that cushions the eyeball, protects it from injury. Now sometimes a little bit of that fat needs to be trimmed as well. So the procedure simply really consists of cutting out carefully a strip of skin with attached muscle, and then sometimes trimming fat, and then basically sewing it all back up. So it sounds very simple, doesn't it? But it needs a fair bit of planning and very careful measurements. If we don't take enough, then we're going to find that the result is not really visible. But if we take too much, that's going to be much worse, because then the patient won't be able to close their eye. And as you can imagine, that is distressing, and it can lead to long-term damage to the surface of the eyeball. So really we have to find that that middle ground between not taking enough and taking too much. Fortunately, the upper lids are fairly forgiving, and it's actually, in practice, it's quite difficult to take too much skin as long as the measurements have been done correctly. The other thing to take into consideration with eyelids is symmetry. That is to say, left and right looking the same. Most people are not symmetrical, and as we get older, the asymmetries in our faces tend to get worse, and this is particularly true with eyelids. We can't always completely correct those asymmetries, but what we can do is we can usually make them a little bit better. And so one of the main aims of this surgery is to identify asymmetries and take this into account when we do the surgery, to see if we can improve the symmetry of the face. Now, eyelid surgery is usually a quick surgery. Upper lids takes usually around 45 minutes. Lower eyelids maybe a little longer, an hour or so. I find that it's very useful and very important to be able to get the patient to open their eyes towards the end of the surgery to check the work. Now, this of course means that the patient can't be completely under a general anaesthetic in order for us to do that. What we can do is we can give a so-called twilight sedation, which is one where the patient will usually be very floaty, very relaxed, very dreamy, and often pretty much sleep through the entire procedure, but can be roused. And so towards the end of the procedure, I will actually wake the patient up and ask them to open their eyes. People are sometimes a little bit worried about this. Doctor, am I going to feel any pain? Well, what we do is we give a little bit of a stronger twilight sedation at the start, and then we infiltrate the area with local anaesthetic, which is extremely effective, makes the area go completely numb, and then the patient feels no pain for the rest of the procedure. What about the post-operative course with eyelid surgery? Usually we are going to expect some swelling and some bruising. But one thing that's important to know is that you can still open your eyes and you can still see out of your eyes. So you don't go home with patches or anything like that. There are small sutures with the upper lids and with the lower lids. There will be visible sutures. So you may, we do recommend that you bring in a nice big pair of dark sunglasses and maybe a floppy brimmed hat so that you can leave the facility without attracting too much unwanted attention. People go home, usually later that evening they'll find that as the anaesthetic wears off, they do start to get some pain in the area. We do provide painkillers for that. And the other thing that we put on the script is a routine prescription for antibiotics. Now, I don't think I've ever had a post-operative infection after an eyelid operation, not from memory anyway, but we still want to make precautions that that doesn't happen. It would be really unfortunate if someone got a severe infection. I do obviously operate to the strictest aseptic protocols in order to minimise the risk of any kind of infection during the surgery, but we just like to have that extra cover after the surgery, and so that's why I give antibiotics as a routine. Let's talk a little bit about a lower eyelid surgery. It is more complex and there's probably a little bit more that can go wrong. So there are two basic approaches to lower eyelid surgery. We can go from an external incision that just runs underneath the eyelashes, or we can actually make the incision from the conjunctival surface, which is behind the eyelashes. Both have their merits and drawbacks, and the individual decision is going to depend on what I find on at the examination, and I will always, of course, discuss the options with the patient. But usually what we do need to do is trim some of the fat. Now, we talked about fat in the upper eyelid. The fat is actually all around the eyeball. In the lower eyelid, it's visible as 3 separate little pouches, and sometimes we only need to trim one of those, but more often than not, it's probably all 3. Another more modern procedure, which I do quite often, is to mobilise the fat out of its socket, as it were, but instead of trimming it, reposition it, and we can actually fold the fat down to fill the tear trough here. As you can see, I haven't had it done. Probably should get it done one day, but this is sometimes a very effective way of reducing that shadowing in the tear trough there, at the same time as tightening the skin and reducing the overall bulge of the lower eyelid. There are certainly some people who should not have lower eyelid surgery, and these people can be easily identified at the time of the initial examination. Very often I find that people who think they need eyelid surgery actually don't need eyelid surgery at all. What they need is revolumisation of their mid-face. What's happened is that the fat pad of the cheek has dropped and gotten smaller, and it has revealed the tear trough and the structures of the lower eyelid, and as long as they can be covered up again, the problem is solved. So revolumisation of the midface can be achieved as an office procedure, non-surgical, just with dermal fillers which are injected, and that's something that I very commonly do. But there is another option which is probably longer lasting and a little bit more natural, in that we're using the patient's own tissues, and that is a procedure called fat transfer. I'll talk a bit more about fat transfer in another talk.